All right. So our first speaker brings depth and passion to the care of our youngest patients. I always call them our star patients. She's Dr. Sarah Ngodri. She's a pediatrician and the only pediatric pulmonologist at the Kolebu Teaching Hospital. I told you we bring the best facilitators. She has a special focus on childhood respiratory disorders, including asthma. Her work places her at the front line of managing most of the challenging cases with pediatric airway conditions that we see. This session is really important because managing children is not just about prescribing, but making sure that whatever you prescribe to them, they're able to take it, the technique and all that. So she will touch and explain all this. Kindly join me to warmly welcome Dr. Sarah Ngodri.
Thank you very much to the Society of Family Physicians of Ghana for inviting me. I know that you carry the nation's health on your head, so I'm very excited to be with you this afternoon. So currently, I run the pediatric pulmonology clinic at Kolebu Teaching Hospital. That functions as well as the severe asthma clinic. So those who have difficult to treat asthma, those who have had near fatal asthma attacks are in that clinic with a host of other respiratory conditions. I'm also very much interested in spirometry. So we do spirometry, and recently we've started doing bronchoscopy as well. So you know where to refer the children who you think may need such service. So this afternoon, I'm sharing my thoughts on navigating childhood asthma. I call it navigating because I think that sometimes it's really straightforward, but a few times it can be meandering and you have to meander along with the child so that you can get the best outcome for the child. I thought I'll be the second speaker, so I brought a small quiz to make sure that nobody is tired from the first speaker, but now I'm the first speaker. So you can put your answers in the chat, but I'm sure as we go along, we will answer these questions. The first one is that asthma cannot be diagnosed in a child less than 1 year old. So it's either true or it's false. And then nebulizers are generally more effective than spacer devices for delivering salbutamol in acute asthma. And every child who has asthma needs a lung function test. And then an obstructive pattern on spirometry is diagnostic for asthma. And every child who has asthma should be on an inhaled corticosteroid. I don't know if some answers came in the chat. Okay, so I started with that little quiz. Throughout the presentation, I'm going to be sharing some of the interesting cases that I've seen with you. And then beyond that, I want us to look at why we should bother about asthma. We'll try and define and explain asthma, look at testing, and then look at management for asthma. These are abbreviations that are standard that I'm going to use. I think the only one that a few people may not be familiar with is FeNO, which is fraction of exhaled nitric oxide, which is a marker of eosinophilic inflammation. And in children, usually asthma has an allergic basis, so they tend to have eosinophilic inflammation. My first case to tell you about is imported from when I was training in Cape Town. And this is a very well-resourced setting. So it's a 13-year-old male who had lots of social issues, parental drug abuse, was living with grandma, fostering problems, and so on. He had 3 ICU admissions for asthma since he was 7 years old, and a history of recurrent nosebleed as of the time I had met him. Every time he was discharged on inhaled corticosteroids, but his follow-ups were very irregular, which is typical for such a family setting. So he was being managed by the allergologist, and then they sent him to us because they thought that he had uncontrolled asthma or there was something else going on with him. When we evaluated him, we saw that he was stunted, he had clubbing of the digits, And looking through his full blood counts over a long period, we saw that he often had thrombocytopenia. So like I mentioned, this is a very well-resourced setting. And in those settings, they have FeNO, which I understand the medical block in Kolebu is procuring soon. So his FeNO was 5 parts per billion. And FeNO is usually high in eosinophilic inflammation. In children, you are looking at about 35. And then his spirometry showed a fixed upper airway obstruction. This one, you have to look at the, you will have to look at the, you will have to look at the curve, okay, not just the numbers. So on spirometry, curves have like their typical looks. And when you have a spirometry pattern that is looking box-like, then that's a fixed upper airway obstruction. So that was what he had on spirometry. And then we went ahead to do a chest CT scan for him. And this showed tracheal stenosis and bronchiectasis of the lower lobes bilaterally. Bronchiectasis is basically lung distraction. So what happens is the airways get dilated, the pull mucus, they get infected, that dilates further, they pull mucus. So it's this vicious cycle that's happening in the lungs and gives them a chronic cough unless you intervene. So his final diagnosis was a tracheal stenosis. And as you can tell, this is treated differently from asthma. So he went in for tracheal dilatation, repeated tracheal dilatations. The second case is back home here. It's a 6-year-old girl who had a very long history of nocturnal cough and now presented to me with recurrent episodes of difficulty in breathing. When the symptoms started, the child was seen by ENT and managed for gastroesophageal reflux disease. The mom at the time had asthma. Later on, I think a year later, I went on to diagnose the sister also of asthma. She was 6, and at the time, she could not perform spirometry. So when children can't perform spirometry and you want to be sure that this is asthma, you can do a trial of inhaled corticosteroids for them. So that was what I chose to do. But when she was on the corticosteroid, she was now having more episodes. And the episodes presented in such a way that the aunt, who is a doctor in the US, was worried that the child was hyperventilating rather than having asthmatic episodes. It became so bad that at a point, I also began to think maybe this wasn't asthma, maybe there was more to it. So I went to medium dose ICS. I switched to ICS-LAMA combination. The child was still not better. Issues came to a head one evening when she had collapsed and she went to a facility and they did ECG. And because she had very abdominal movements that were unusual, I should say, together with her respiratory presentation, they did an ultrasound, it was normal. So they were going to do a head CT scan. And then I said, no, it was okay. They should hold on. And I did that because at this point, I was beginning to think that this was somatization. And sometimes in somatization, the more you investigate, the worse the symptoms become. So I said, no, we should stop. I asked that they bring her in. I wanted to do the spirometry one last time, even though the first time it wasn't successful. I thought that this time, even if I could just get an FEV1, I would see whether it had a positive bronchodilator response. So that was what I did. And I don't know if you can see the numbers, but her FEV1 was minus 1.94 Z-score. So in pediatrics, we use Z-scores. And the lower limit of normal is minus 1.64 Z-score. So it was borderline normal. And then when I gave her a bronchodilator, there was a 24% change, increase. And we use 10 to 12% as a cutoff, and a lot of pediatricians will do 10%. So if you have a 10% improvement in your FEV1 on bronchodilator, that is diagnostic for asthma. And if you look at the curve upwards, you could see that really I got an FEV1. I couldn't get an FVC, but I set out to just get an FEV1. So then now I was more confident that this child had asthma. So I started her on an ICS formoterol combination at a very high dose using a spacer. And the child just did well. I followed her up for a year. I'm still in contact, but now they don't come to reviews frequently. So for the 1 year that I kept a close eye on her, she did very well. We were able to bring down doses of medications and so on. So this was a very challenging case to diagnose. I'll share yet another case. This is a 9-year-old girl who was going for upper GI endoscopy, and then the gastroenterologist thought that she wasn't breathing really nicely. and so sent her to me. So when she came, the history was that as a toddler, she had wheezed 1 or 2 times. And then along the way, her mom died. And since her mom's death, she was now having repeated severe episodes of asthma. It was so bad that her classroom was on the first floor. They brought the whole class down because she couldn't climb stairs. So on examination, she was obese. You could see that she was pampered, the family setting. I think everybody was compensating for the loss of her mother. When I did a spirometry for her, it was totally normal. So I spoke to them, took her off inhaled corticosteroid. She continued to do well. But ideally, I wanted to do a repeat spirometry. She refused, but as long as she's well, that was fine. I sent her to the clinical psychologist. So I must say that made a very big difference in her life. So why are we talking about asthma? Chronic respiratory diseases are a leading cause of death, with about 4 million deaths as of 2019, and several more million cases globally. And of all the chronic respiratory diseases, asthma has the highest prevalence. About 10% of children and adolescents have asthma. And in low middle income countries, we have more death and more disability from asthma as compared to high income setting. Asthma is a heterogeneous disease. You can probably deduce this from the cases that you see already. They don't present in the same way. And especially for children who are not even able to verbalize their symptoms, it's more diverse. And usually it's characterized by chronic airway inflammation. That gives them a history of repeated respiratory symptoms. So they may come with cough, difficulty breathing, just not being very good, not feeling very good, poor exercise tolerance. They want to be carried along. Some people will have early morning nausea and vomiting. They wheeze, some may wheeze, but in children, you are very lucky to hear wheeze, especially in the infant to toddler group. You are very lucky if you hear wheeze. They tend not to have the characteristic wheeze that we know about. And the symptoms come and go because they have expiratory airflow limitation, which is that when they're breathing out, the air doesn't come out really nicely as compared to when they are breathing in. And this is not there all the time. So sometimes you see the child is very well, and sometimes they have all these symptoms. But what worries us is that, of course, asthma can kill. So physical examination usually is not helpful. Occasionally, you may find somebody with bronchi or a wheeze, but that's rare, especially if they are not having a very an acute episode at the moment. And then for those who've gone for a long time, you see that they are hyperinflated. Their chest may be barrel shaped, or there may be subtle hyperinflation, which is that when you percuss, you find that they lose cardiac dullness. You know, when you're percussing, the cardiac area is usually dull, but you find that these people, is resonance there. I always say that if you think it's asthma and you pick a lot of signs, clubbing, stanting, hair very thin, so if you pick many things, lymph nodes, then it's not likely to be asthma. Asthma usually, apart from the wheeze and maybe hyperinflation, you don't really pick much. Of course, unless they are in extremis, then they are flaring, they are sinuses and so on. But we all know what those are, so I won't spend time on it. So how do you now test for asthma? The gold standard is spirometry, but there are many challenges that are with spirometry. Usually you start at age 6, although a very well-motivated child, I sometimes do it for 4-year-olds, 5-year-olds. but it's very difficult. You could spend 2 hours doing that for one child. You need equipment that is expensive, well maintained. You must calibrate. It responds to the weather. The operator needs to be very well trained. The interpreter also needs to be astute. Sometimes the requests come without adequate history. So the whole thing can be quite complex. And apart from the fact that you may not have the facility, when you manage to send your child outside, it's not a one-off test. Okay, so you are supposed to do one at diagnosis to confirm your diagnosis. When the patient is on treatment, about 3 to 4 months, it's assumed that you've gotten on top of their symptoms. You do one, and that establishes for you their baseline lung function. And then about every yearly, you do one. But in other settings, every clinic, you do one. So people see what's going on. So this is a picture of me trying to do spirometry for a child. So that's what the equipment looks like. Sometimes you can occlude the nose. Sometimes the children don't like it. So you can also set your machine so that you don't occlude the nose and so on and so forth. So what are you going to find on spirometry? When you do spirometry, you find that FEV1, which is the fraction of the air that they exhale in the first second of the test, is low compared to the amount of air they exhale throughout the test, which is the forced vital capacity, which I hope we all remember. So you see that there's a reduced FEV1 compared to FVC. I see a lot of lung function done elsewhere, and I see that they are reported, the cutoffs are reported in percentages, but please, in pediatrics, we use Z-scores because in pediatrics, everything is dynamic. Weight, Z-score, height, Z-score, everything, blood pressure, central or Z-score. So in pediatrics, we use Z-scores. Or you can, when you get the result, sometimes you can translate in Z-scores, but it's just easier for us to just see Z-scores. So you see a reduced FEV1 compared to FVC, or if you happen to have spirometry on multiple visits, you see that there's excessive variation in lung function. There's about 12% or more difference between visits. If for any reason you were not convinced, you started the person on inhaled corticosteroids and you wanted to do it after 4 weeks to see, you will see that the lung function has improved. And sometimes spirometry is normal, but for whatever reason, you really want to demonstrate that this person has asthma. Maybe there are differentials that are of equal weight you are considering. So you can do bronchial provocation. It's supposed to be done in the lab, but I don't have a lab, or we don't have the lab in the pedics block. So we sort of run around with the child, but it's a very unsafe thing to do because you're supposed to do it in the lab. They're on a treadmill, you work them, you do it so that you have resuscitation equipment. So if anything happens, you can sort them out. But if you do bronchial provocation, you see that there's a decrease in lung function. So the first thing we look for on spirometry, as I said, is a decrease in FEV1 compared to FVC. So that's an obstructive pattern. The next thing you want to demonstrate is that the obstruction responds to a bronchodilator, because there are some other obstructive conditions, they don't respond to bronchodilator. So basically, when you give them a bronchodilator, their lung function improves. So the baseline FEV1, which is the one you've done at first, improves by 10% or more. FVC, an improvement in FVC is also considered a positive test, not just the FEV1. And this bronchodilator responsiveness, you should do even if FEV1 is normal. Again, I've seen that people do spirometry. Once it's normal, they stop there. But the thing is to bear in mind that all the values you're comparing it with may not be for the child, sort of, because these values are derived from data, which is not ours and so on. And children are different. For instance, if you find people who box or swim, they tend to have very good lung function. So that's what you look for. Or as I said, treatment with ICS. You can do this, you can do spirometry, even if the patient is already on inhaled corticosteroid. But primary care, how many of us have spirometry? There comes in the peak flow meter, or what we call the peak flow metry. It is better than going on clinical symptoms alone. Currently, peak flow meters go for between 60 cedis and 100 cedis. Sometimes people have peak flow meters in their clinic, and what they do is that they get a lot of mouthpieces, different mouthpieces, because you're supposed to use a mouthpiece. This end has the mouthpiece, it goes into your mouth, you stand up, you take in a breath, you blow out as hard as you can, and there's a lever that you move. So people have one meter, and then the children have different earpieces, mouthpieces that they use. That's what we used to do in the children's block. But what you should avoid is that you should always use the same meter for the child, because between meters, there may be a difference of about 20%. So you should always use the same meter for the child. But my experience has been that children are usually not motivated, especially if you give it to them to go and do at home. And also, it's maximum effort, and some children just don't do that. And because there isn't a graphical display as you may have in your spirometry, that's also something that doesn't work well for them. But if you are using a peak flow meter, you find that morning and evening, there's a variability of how much air you blow when you blow in the peak flow meter. If you measure over 2 weeks, you see a variability, a diurnal variability of 13% or more, or 15% between visits. Or if you do an exercise challenge, you do an exercise challenge, the peak flow, how much air you blow, falls by about 15%. So you can also use this to do make a diagnosis. Like I said, it's better than relying on symptoms alone. And then you can also give a bronchodilator, just like you do in spirometry, and look for an increase in FEV1 after you give the bronchodilator, or when you have given them inhaled corticosteroid. Now, children can't do any, small children can't do any of this. Spirometry, as I said, is challenging below 6 years. And the peak flow, they are not interested. So diagnosis in children 5 years or younger it can be challenging. And the thing is that asthma is not the commonest reason why children younger than 5 years wheeze. Even when they have asthma is not the commonest reason why they wheeze. They wheeze mainly because of viral upper respiratory tract infections. So we use a probability-based diagnosis in that age group. And in that age group, the differential diagnoses are very important. You have to think about the other things apart from asthma as well. Although if they have asthma, you should diagnose it, because otherwise they suffer a lot. They really do suffer. So the features that suggest asthma in children 5 years or younger, they may have a cough, but this cough is worse at night. It may or may not be accompanied by wheezing and breathing difficulties. When they exercise, they cough, they laugh, they cry, they cough. Or when they are exposed to certain things, tobacco smoke, strong scents, they cough. The one thing that I found to be very good to use is that they cough when they don't have a cold. So when you're asking, you say, oh, he doesn't have a cold, he's jumping up and down like every child else. Does he cough? And when they say that, it's quite sensitive. And then they have recurrent wheezing. They may wheeze during sleep when they don't have a cold. They may wheeze when they do the same activities as for cough. Their difficulty in breathing comes with exercise, laughing, crying. They have reduced activity compared to their siblings. They don't want to run as much at PE. They don't want to play. And those that play football, you see that they want to be keepers rather than strikers. You find that they tend to express some exercise intolerance. And the past of family history of allergic disease, atopic dermatitis, rhinitis, food allergy, or asthma in a first degree relative is very important. So what can you do since you can't do lung function tests? So the history is very important, as I've said, but you can also do a therapeutic trial of inhaled corticosteroid. How do we do that? So you've seen the child, you are thinking this is asthma. You give them an inhaled corticosteroid, and then you give it to them for about 2 to 3 months. Then you stop. And then you stop for about 2 to 3 months. They have to document their symptoms while they are on it and while they are off it. And the reason is to find out whether they are worse off it than on it. If they are not worse off it, then that is not likely to be asthma. But if it's asthma, when they are on it, they have an improvement. Once they go off it, they become worse. Then you can test for allergic sensitization, but this may be negative in people with asthma, and you may have allergic sensitization and you don't have asthma. Chest X-ray comes in usually when you're thinking about the differential diagnosis. Lung function tests, just in case you are working elsewhere, there are lung function tests that children less than 6 can do, because those ones don't require them to blow hard and so on. There are some done at tidal breathing. You are just breathing and they can do. And like I mentioned, FeNO is also very important. It's not likely to be asthma if the symptoms started in the neonatal period. It's not likely to be asthma if they have had a previous severe pneumonia, if they are failing to thrive, if they have focal lung or cardiovascular signs, it's not likely to be asthma. They have clubbing, it's not asthma. Their symptoms come with vomiting, although asthma can present like this, but it makes you think more of GERD than asthma. The reason is continuous, because in asthma, the flow limitation is variable. So if the symptom is continuous, every single day they are wheezing, it's not likely to be asthma. And if they are hypoxemic outside you find a wheeze, not so bad, but their oxygen saturation is just so persistently low. That's also not likely to be asthma. So we're talking about testing and so on. Why do you need to make a correct diagnosis of asthma? Why can't you just go based on history alone? So there's this thing done in Canada, 613 Canadian adults who had a physician diagnosis of asthma, but when they did spirometry and those who were negative had bronchial provocation tests and followed up for a year, 33% do not have asthma. And then a similar thing done around in about 260 British adults, the same thing. When they did spirometry for them, a third of them do not have asthma. So it's very important that we try and test. Difficult diagnosis, come back to your history. Look at your differential diagnosis. Is this TB? Because I found a lot of TB that presents just like asthma. They wheeze because they have lymph nodes sitting on the main bronchi. So they tend to wheeze. And then, as I said, you can do a trial of inhaled corticosteroids. You can repeat the spirometry later. And if you think this person has asthma, has been on corticosteroids, but their lung function does not improve, the recommended thing is that you reduce your inhaled corticosteroid or you stop it. Okay, and you go back to your history and examination. And then, of course, consider specialist referral. Now, asthma COPD overlap is, so on the slide, I said it's present in a few people, but I've seen a lot of it. And that is what happens if asthma goes untreated for a long time. The airway is remodeled. They do not respond to bronchodilator, so they have chronic obstructive pulmonary disease. Suppose you refer to the specialist, what may they do? They may do bronchial provocation, I've mentioned, they may do imaging, allergy tests, pheno, other lung function tests. We can also do bronchoscopy. Okay. Some children with asthma have only cough as the symptom. There are people who have asthma for children only when they go to school. And then athletes are a special group. For the elite athletes, some of them tend to present with vocal cord dysfunction. Although history can help you, spirometry is very helpful here. And pregnant teens, I singled them out because they can't do spirometry because of the abdomen. And if the parents smoke, I have some children in my clinic, the parents smoke, and they will tell you that they smoke. Then you also have to bear in mind that obese patients, they may mimic asthma, although they don't have asthma. Some of them are just very deconditioned. So when they do some physical activity, they present as if they are wheezing, but that may not be asthma. Again, spirometry is very helpful here. Expreterms, they may have chronic lung disease of prematurity, and then they wheeze, but it's not the typical asthma. So though we are in a low middle income setting, syndromic approach is not recommended. If you can, even if you can, just get peak flow, 2 or 3 of them in your clinic. The only thing you need to do is to make sure that a child uses the same peak flow meter every time, that you are not going in between peak flow meters. And people can buy their own peak flow meter and take home. You just teach them how to use it, and they document, and then they bring it to you in clinic. So you can see also how they're doing well at home. So now we come to management, and I just want to define a few terms. When we say control, it means the extent to which a patient is expressing the symptoms. How frequently are they having symptoms? How bad are those symptoms? Or the extent to which medications have reduced the symptoms now that you are treating them. And control is not only about symptom. We look at a symptom, but also the risk of adverse outcomes. So what I mean is, for instance, if someone has been to the ICU for a near fatal asthma, you will not put that person in the same category, even though they are not now having symptoms. You will not put them in the same category as someone who is also not having symptoms, but has not been to ICU because of asthma attack. And then when we say asthma severity, we are looking back. So it's a retrospective label. You don't see somebody now because they are wheezing so bad, you say this is severe asthma. So that label is about how easy it was for you to get on top of symptoms and to prevent exacerbations. And it's useful to identify those who need high-dose medications and other treatments. I just want to say we should beware of saying things like mild asthma. This person has mild asthma. The reason is that even though their presentation doesn't strike you as severe, they can also have a fatal attack. When we are managing, we want to have symptom control. We want to minimize their risk, and this should include lung function. You should make sure that the lung function isn't low. or if it is low, then you know how to characterize them and manage them. Sometimes we say asthma remission, but when we are talking about asthma remission, which is that your asthma has gone to sleep for many years, there should also be lung function as well. So it's not advisable to just let go of those people without having a lung function. And it should mean the same thing to you as it means to the patient and their family. So for instance, you could say that your asthma, you haven't had an attack for a long time, but if you don't know how to say it, they may think you are telling them that their asthma has been cured. Does your patient have good control? We know from studies that more than 60% of patients in our clinic are uncontrolled. And what are the factors that affect control? The older age, the teenage, they are just very special. Wherever you go, nephrology, everywhere, the teenage, they are special. They don't want to use medication. They want to be like everybody and so on and so forth. And asthma medication use, those who are not using inhalers, those who prefer salbutamol, they are the ones that's and oral prednisolone, they are the ones that are likely to have poor control. Studies have said if you have been living in the city early in your life, and if you have concurrent allergic rhinitis, the allergic rhinitis really makes sense because it's one airway. So when something happening somewhere will happen there. So the strategies now, since 2019, nobody should be on SABA alone. Since forever, everybody should have an asthma action plan. It should be written for them. They should know what to do when they have an attack. They should know what their daily medication is. Everybody should be trained in using their inhaler. So what this entails is that when you give a child an inhaler, you train them how to use it. You make sure they know how to use it. Every clinic visit, they should demonstrate for you, not say it, they should demonstrate that this is how they are using their inhaler. If they've done well, you congratulate them. If not, you reinforce the training. So that means every clinic visit, they have to bring their thing so that you see. If they are on a spacer, they should also bring the spacer because sometimes the spacers are not good enough for use. And we recommend that children less than 12 should use a spacer until they themselves have proven to you that they can do well without a spacer. Even then, even if their technique is good, but they are not controlled, you should consider putting them back on a spacer. And if you have the facility, you should keep repeating their lung function test. So now I just want us to look at the ICS, the doses and so on, because that can get really, really confusing. And we don't have, even though there's so many different devices in the world at large, on the Ghanaian market, we don't have that much. So we can concentrate only on the ones that we have so that we can get a maximum yield. So now I bring another case. I saw about 3 months ago. So this is a 1-year-old with a history of repeated episodes of difficulty in breathing, but they were always preceded by colds. And since age 6 months, has had 4 short admissions for nebulization at PML and antibiotics because of breathing difficulties. At the time that he came, he looked very well, but the resident thought that his chest was hyperresonant on auscultation, and I confirmed that it was hyperresonant on auscultation. Full blood counts, chest X-ray, they didn't really say anything. So I have a live audience here. What is your opinion on further management of this 1-year-old? So before we come back to the child, I just want to reiterate that before you start inhaled corticosteroid treatment, always, if you can, confirm your diagnosis and document it if possible. Okay. The teenagers, they come with asthma that is not asthma. It's very helpful for them as well. Record the level of symptom control so you know where you're starting from. And of course, if you've done a lung function, you document it. Because if it's not asthma, no matter what you do, it's not asthma. So like I said, on the Ghanaian market, as far as I know, so these are the things that I find commonly. Although once in a while, someone be treated abroad or so on will come with something, but these are the ones. So we have beclomethasone dipropionate, the standard particle, because there's fine, ultra fine, all those ones. So on our markets, we have Beclate, Beclocort, Clenil, Soprobec. They are all beclomethasone. Then we have fluticasone. And I always think how nice fluticasone is because the brands on the Ghanaian market are not many. Flixotide, you just need to remember that one. Then we have budesonide, the standard particle size, Pulmicort on the Ghanaian market. There may be some more, but these are the ones that I find commonly. Then we have ICS formoterol, we have Foracort, and then we have Symbicort, on the market. So you want to start inhaled corticosteroid for children. It's divided into age categories. Okay. So for children 12 years or older, it's based on their initial presentation. Although if you really push me or if you are really stuck, I would say that where you start from is not as important as what you do afterwards. Because once you start a child on inhaled corticosteroid, you're supposed to keep an eye on this child. If the child is having symptoms despite being on inhaled corticosteroid, you look at what we call the modifiable factors, which I'll go into soon. And then if all those things are sorted and you are sure this is asthma, you increase it. And if you start a child and then they are no longer having symptoms, you decrease it. So where you start from may not be as important as what you do following on, but you want to do your best for the patient. So this is the guidance. If they are having symptoms less than 3 to 5 days a week and lung function is normal or mildly reduced, not very concerning, there are 2 things you can do. The preferred regimen is that they are on as needed only low dose ICS formoterol. So we have budesonide formoterol on the market, as I have shown earlier. The dose is 206. And for Foracort, we have 206. For Symbicort, that becomes 164.5 for them. I've put it at the bottom of the slide. Alternately, especially if they've been on ICS and SABA before they came to you and you don't want to change it because it's working for them. Alternatively, you can put them on beclomethasone for the whole day, 200 to 500. Fluticasone for the whole day, 100 to 250, which is that you may do 100 BD. Budesonide, 200, 400. But if they're having symptoms most days, then they need to be on regular maintenance therapy, okay? And in this case, the preferred is also the combination therapy, ICS formoterol. There's one single inhaler. So they take it, the 206, 1 or twice daily. And then they also use it for their reliever. So the child is on, say, permit me to mention a brand just to make it more easier. So if the child is on Symbicort 160, 1 morning, 1 evening, when they have an attack, they still have to use the same Symbicort. Okay, I see children 12 years and older, they're on Symbicort, but then they also have salbutamol. So when they have an attack, they use the salbutamol, but then maintenance, then they use their Symbicort. But now we want people as much as possible, if they are 12 years and older, to be on SMART therapy, which is single maintenance and reliever therapy. So the one inhaler that they have is what they use for maintenance and then they use for relief. But they can also be on a combination of ICS LABA. Once it is not budesonide formoterol, you can't use it as a reliever. So then they need a SABA. But the reason why they are on ICS LABA combination and not ICS, plain ICS plus a SABA is because they're having symptoms most days. So those ones you want to treat with more medication. So they have ICS LABA. And then because it is not SMART therapy, you give them a SABA. SMART therapy can only be done with a combination that has formoterol in it. So if you are using an ICS combined with something that is not formoterol, then, and so far is budesonide formoterol, then you need a separate SABA. But if they are also having nighttime symptoms, then you have to increase the dose of the ICS formoterol that they are on. So they are on ICS formoterol max, but then they take 2 inhalations twice daily. But when they have an episode, then they take 1. And then the one that they take when they have an episode can be repeated. For children 12 years or older, they can go up to about a total of 12 doses a day, although that is rare. It's extremely rare. And in most asthma action plans, they will tell you that by the time you get to 8 for the day, you should be heading to the hospital. So that is what you do when you start ICS. I think the thing to bear in mind on this slide is that if you are 12 years and older, you should ideally be on SMART therapy, which is single maintenance and reliever therapy. As for the doses, we can always open BNF or look at GINA and anything online and find the dose. Now for children 6 to 11 years, their initial treatment is not SMART therapy. Okay, so if they are having symptoms not frequent, less than one episode a week, I mean, they can take a low dose ICS, and they take it whenever they take their SABA. Because remember that nobody should now be on SABA alone. So previously, this person, they have an episode, they take salbutamol. But now when they take the salbutamol, they have to take a low dose ICS. And the low doses are what I've tried to put: the beclomethasone 100 to 200 daily, fluticasone, and budesonide. But once they're having symptoms 2 to 5 days a week, you should have them on maintenance therapy. That is a daily low dose ICS plus as needed SABA. But they are also having nighttime symptoms. Then you have to put them on medium dose ICS. So you basically just increase the dose. But here, you can also start them on an ICS formoterol combination. Okay. And when they are on ICS formoterol, then they can also use it for their reliever therapy. But if they are on an ICS combination and it's an ICS LABA, which is not formoterol, then they can't use it as a reliever. Then they also need a SABA. But if they have ICS formoterol, then they can use it as their reliever as well. And if they are having a lot more symptoms, basically you just increase the dose. And for these people, if their initial presentation is an asthma emergency, let's say you saw them, they had a very bad attack, and you've had to give them corticosteroids, you cannot start with the as needed therapy that I spoke about, like the top of the slide here. They have to be on maintenance therapy, and then you would choose to give them MAT or a medium dose ICS LABA combination. This can be confusing, but we have these algorithms available. And also just remember that whatever you do, see your child and see whether what you are doing is working. Okay. So with the child that I just presented, so that was this 1-year-old toddler who was having these episodes. What we chose to do for him keep seeing him, and if it's too little for him, we'll take it up. Now, this is a 9-year-old boy. This boy is very naughty. The mother is a doctor, and she's not afraid to say that this boy can really malinger. If he doesn't want to go to school, if he doesn't want to do something, then he's sick. And he had been to the OPD several times because of abdominal pain, nausea, or diarrhea. And now he presented to me with a second episode of a wheeze in 2 years, for which this particular episode had been going on for a few days. So he was being nebulized with salbutamol over a few days. Mom, who is a doctor, says that when he is asleep, he is not wheezing. But once he wakes up, the wheeze starts. So mom has allergic rhinitis. There's a personal and family history of urticaria. On examination, he was small. His BMI was on the -3 Z-score, and he had a fungal rash of the back of the neck and the face. The respiratory rates, it was going up and down. If he saw you looking at him, he will go up. If he is not aware, then it's normalized. Or when you are chatting with him, then it's down. He was able to produce this inspiratory sound that sounded like a wheeze, but I mean, it's inspiratory. I know it's not a wheeze. But then when I listened closely, I saw that there was also a very soft actual wheeze. Then you do that, you hear it when you distracted him. And he had allergic rhinitis. His chest X-ray was neither here nor there. His spirometry was normal. His FEV1 was on the -1.3 Z-score. Remember, we said the lower limit of normal is -1.64, FVC -0.455 Z-score, FEV1 over FVC -1.49, which is better than -1.64. So spirometry was normal. I gave him a bronchodilator. I did give him, but I don't show it here. And there was no reversibility. So, I mean, I wasn't sure he had asthma. I didn't know what he had. I was quite concerned that he was small and he had a fungal rash. I mean, is it primary immunodeficiency? What is it? His abdominal symptoms. Maybe he's not malingering after all. Maybe there is something else. So I had some differentials on my mind. I decided to give him Symbicort anyway. I saw him, I think 3 months later, he was doing very, very well. So now I've given him a peak flow meter so that he can document his peak flow at home for me. And then on the next visit, I'll also do a spirometry to see if his values at home are normal, and then the spirometry is normal. I would begin to bring down the medication. Now let's talk about treating children 5 years or younger. Can be really confusing. I've just given you an example of that child who is in and out of hospital. I've had an experience with a baby that I diagnosed with asthma. Anytime he went on admission to one of our facilities, they would tell the mother to stop because it's not asthma. But this child had atopic dermatitis, had allergic conjunctivitis. The sister had asthma, but anyhow, put him when he goes to hospital, they would tell him to stop. But when I told the mom to stop listening, the child has been doing well. They were admitting almost every month. They've not been on admission for a long time. So if you really diagnose asthma and treat them, you make such a difference. But the problem is that there are so many differentials. So if you're not careful, you'll be giving people steroids who don't need it. So what are the indications for children 5 years or younger? If they have asthma symptoms more than twice a week, if they've had one exacerbation requiring a hospital visit, if they have a recurrent viral wheeze, you should start inhaled corticosteroid for these children. And the first step is a low dose inhaled corticosteroid. So that will be 100 micrograms of beclomethasone for the whole day, or fluticasone, 50 micrograms. Usually fluticasone, beclomethasone, you divide by 2. It's not a formula, but fluticasone is always about half the dose, yes. So when you do that, you are not seeing top. You can double the dose, okay? If you are still not seeing top, consider sending to a specialist, but you have to check for what we call the modifiable factors. And step 3, definitely send to a specialist, okay? So for all ages, when you are starting inhaled corticosteroid, a spacer. Children less than 12, they need a spacer. Because if you look at the technique for taking, say, salbutamol, they have to inspire and keep inspiring. They have to have a deep inspiration. And a lot of children cannot manage that. Now, even for those who can manage it, sometimes you have to think about their tidal volume, okay? And see that even if they're taking a deep breath, how much of this 100 microgram is it that they are taking? Some children older than 12 also need a spacer. And I think I have a case that will give you an example. And so once you start it, 2 to 3 months later, you should see them and review. On that visit, you talk about everything, you give your asthma education and so on. You look at their spacer. Is it okay? Is it correct? The cleaning, you should have told them how to clean it, which is that they shouldn't use a sponge, a towel, tissue, brush, anything, because you don't want any scratches inside. There are some spacers that do better when you leave the soap in it. And but generally, when you rinse it in soapy water, you put it in clean water, you rinse it, shake off the excess water, you put it down to dry. So are they doing all that? They have to rinse their mouth. If they are using a face mask, they have to wash the place that is covered by the mask after the use of the. So you see them and see that all these things are happening, and of course that their symptoms are better. Now, if their symptoms are not better, maybe it's the inhaler technique that's a problem. Maybe they're actually not taking the medication. So you need to do that. And then when you ask them, are you taking your medication? They will say yes. But if you ask in an open, empathetic manner, like, yeah, it can be really hard to remember to take this medication, right? So you are hearing something. Sometimes you see that they smile and so on. So open-ended questions, empathetic, then you get the answer. And ongoing exposure. Some parents smoke. They will tell you. Some have lots of, like their household has lots of livestock. So there are some houses full of damp and mold. We know that some children also don't do well with cockroaches, bush burning. I have children who in their schools, they burn the rubbish in the school. It's such a problem. So those days that they burn the rubbish, they have a problem. Children, I know a child, they've changed schools like 6 times. One school, the mother thought it was the carpet because it was having problems. They went to another school. Most of the children use spray. They went to another school. The teacher uses perfume, and they just had to keep changing. And of course, when you consider all these things, also consider alternate diagnosis. In our environment, TB is quite common. When do you review when you started on ICS? A week after a major exacerbation, 1 to 3 months after starting treatment. I choose to see them in 1 month because often they are overwhelmed. Sometimes when you diagnose, at the same time you are diagnosing allergic rhinitis, allergic conjunctivitis, so they get overwhelmed, and then the medication may not go very well, spacer use and all that. So I choose to see them one month after. But after that, it's 3 to 4 monthly when I determine that they have a very fair understanding of the disease and the management. Yearly visits are also possible if they've not been having asthma episodes for a long time. But people you should see more frequently than 3 to 4 monthly are those who have problems with inhaler technique. That is, you've taught them, but there are still problems. Those who cannot understand their asthma action plan, that's what should they do if they have an episode. You've written it for them, but always they have an episode, either they go to hospital because they are afraid, or they do something separate from what you've written on the asthma action plan. Those ones you need to see frequently. Or those who are either really having side effects of medications or think they are having side effects of medications. Because if you don't see them frequently because they think they're having side effects, they will stop. Otherwise, as I said, 2 to 3 months or 3 to 4 months. Once good control has been achieved, which is that they are not having symptoms and their lung function has improved. If you did the lung function, you need to step down. And the inhaled corticosteroid you should adjust. It's not just about stepping down. You can go up. And sometimes people, you can tell people, depending on how well you know the child, some people, when they have a cold, they want to double their dose. That's a short-term increase. And then day to day, as you said, if you are on an inhaled corticosteroid, that is also your reliever. You adjust it based on your symptom. And then the sustained step up or down, which is that I've reduced it. For the next 3 months, you're on a reduced dose or you're on an increased dose. So this is a girl who's really become my friend. She's an 11-year-old who was in PICU and was referred to me on discharge. So in my department, I say that if you've had asthma, you've gone to ICU, you should be discharged into pulmonology clinic, not asthma. So now they all come to pulmonology because that's near fatal asthma. So an 11-year-old who went to PICU for an asthma episode, she was intubated, she had bilateral pneumothorax and AKI from an asthma attack. She almost died. Before she came to PICU, she was referred from around Dodua. She had been on Symbicort 84.5 BD and salbutamol inhaler PRN for 2 years. Although her last follow-up before the episode was about a year earlier, she was adherent with medication. So when she came to me post-discharge from PICU, she had this rapid shallow breathing. Her chest was all sore from the chest tube wounds. Okay, so now I just want you to think, what would be your immediate management? This child was on Symbicort 84.5. I'm sure we all know what the device looks like, but now she's going home with a sore chest, and because the girl almost died actually. So what I did for her was that I gave her a spacer, because at that time, still couldn't give her Symbicort. I chose to give her one that she could use with a spacer. Okay, so she's on Foracort. Okay, now if you want to take up, consider these things. Is it a comorbid disease? Are there modifiable risk factors, adherence, inhaler technique? You need to do that. Sometimes you go up to a higher dose of the same drug, but you may also change the drug depending on what is happening. And if stepping up of medication, you should consider it a therapeutic trial, which means that you can step up, but know that you may need to come down. If the step up doesn't work, it's better you come down to what you were and consider referring to someone else. And stepping down, I think we don't do very well with stepping down. But if you don't step down, the patients step down themselves, because the the medication load can be such a problem for them. So do well to step down. If not, they will step down themselves. But if you are trying to step down, you should be sure they've had good asthma control for 2 to 3 months, including their lung function. If they've just been to ICU or lung function is very low, that one take longer. Don't step down in 2 to 3 months. And you are stepping down to the minimum effective treatment, which is that they don't have exacerbations, there are no side effects, it's not too expensive for them. Choose an appropriate time. For instance, if they've been seeing you at, say, Kolebu, and they are traveling to Koforidua, where they don't know the doctor, or they are going to somewhere where there's not a doctor, that's not the time to step down. And when you are stepping down, give them an asthma action plan. Okay. There are also some non-pharmacologic interventions we consider. So environment, avoid tobacco smoke exposure, encourage physical activity. And some of them, I find a lot of parents tell their children not to exercise, but with asthma, we ask that they exercise. But if exercise brings on their symptoms, encourage them to let you know, and you advise them to take their reliever before they exercise. Elsewhere, there are structured pulmonary rehabilitation programs, includes nutrition, counseling about disease, weight management, and everything. Avoid exposure to indoor irritants and allergens. Avoid also medications that worsen asthma. Brufen is one notorious one. They should have a diet high in fruits and vegetables and avoid overly processed foods. So damp and mold in homes should be reduced. If there are some anti-house dust mite strategies, so they can employ those ones, it has some benefits for them. And weight reduction, breathing exercises may also be helpful. Some patients have comorbid psychiatric or psychological problems, anxiety, depression that may be related to asthma. You need to refer them appropriately. If food allergy is confirmed, then they have to avoid that food. Now in Accra, luckily we have an allergist. So we should also consider referral to them. When you see them on follow-up, ask of daytime symptoms, nighttime symptoms, activity limitation, frequency of reliever use. And then you ask for risk factors of exacerbation, which are more than one exacerbation. The previous year, if they've had a severe attack, know that they are going to have another severe attack. If they are only taking their SABA, if they have a low socioeconomic status, low FEV1, if they have eosinophils in the blood, these people have risk factors for exacerbations. You need to keep a closer eye on them. Look for medication side effects. We always mention oral thrush. I haven't seen it, but what I normally see is a fungal infection of the nares and mouth area. That's what I see. And of course, the comorbidities that we always talk about. Okay. So again, on follow-up, these are the things you do. If you can measure lung function, do it, assess for other comorbid factors and treatment factors. And as I mentioned, asthma severity is a retrospective label. You need to distinguish between severe asthma and difficult to treat asthma. Difficult to treat asthma so severe asthma is one that requires lots of medications, high doses of medications, but difficult to treat. They have all these factors at play: medication, non-adherence, poor inhaler technique, and so on. And those ones, you look for modifiable factors and treat them. So don't say severe asthma at the time you are starting to treat. All right. And now we don't want to use mild asthma, intermittent asthma, all those things we don't want to use. We don't want to use them. Okay. So this is just the famous GINA personalized action plan thing. When to refer to an expert, difficulty confirming diagnosis. If you think this child is only having asthma when they go to school, if symptoms, you can't control the symptoms. If you think the child is at risk of death, if you think that there are treatment side effects, if there are complications of asthma, you should refer. And what may the specialists do? Allergen immunotherapy, low dose azithromycin. Some people do sputum guided therapy. I don't do that. I don't have pheno, so I don't do it, but it's available. I have one patient on oral corticosteroids. Biologic therapy, we don't have it in Ghana yet, and add-on LAMA. For this one, I just want to mention how you can also use a spacer when you have an attack, even in the emergency room. They don't all need nebulization. You can actually they can use their spacer. So you see what it is they are doing at home that is not working, because the evidence says that using a nebulizer and spacer, the outcome is the same. The problem is that our spacer techniques are not very good. People ask about, how can I prevent asthma? My other child has asthma. How can I prevent asthma in my next child? Avoid environmental tobacco smoke exposure. There's some evidence that if you treat vitamin D deficiency among pregnant women, I don't think vitamin D deficiency is such a huge deal here. Encourage vaginal delivery because there's all this about the flora, the flora of the respiratory tract, and what colonizes when you have a vaginal delivery is different from when you do CS, and the ones that colonize in vaginal delivery happen to give some benefit. Broad spectrum antibiotics before age 1, again, it has to do with the respiratory tract flora. It's like you wipe out all the good organisms and so on. It's not very good. And breastfeeding as well. But breastfeeding also protects against respiratory tract infections, which are the reason people tend to give antibiotics for children. So breastfeeding may help. So the commonest chronic respiratory disease of childhood is asthma. So we see it a lot in primary care, and we should try and get on top of issues. If you can't get lung function, it's an integral aspect of asthma management. You don't need spirometry. You can also do peak flow. And the treatment, you have to take into consideration several personal factors. And I've tried to demonstrate that in some of the cases that I've presented. And when you do that, a vast majority of patients who have asthma, they are very good. Thank you very much.
Thank you very much, Dr. Woodry, for this insightful presentation. I'm sure you are very satisfied listening to all the depth of knowledge she shared within the last hour. I want to say that our capacity is full over the last 40 minutes. So kindly join on our YouTube channel to be able to participate and learn from today's session. This CPD is also proudly sponsored by Get Pharma, innovative pharmaceutical companies who also have a wide range of medications for managing our patients with chronic asthma. So we'll quickly go on to the second speaker, is our very own family physician, consultant family physician, and fellow of Ghana College of Physicians and Surgeons, and also the medical director of Finney Hospital and Fertility Center. Dr. Alanstein Darcy is passionate about teaching and also helps with training with family medicine at the Kolebu Teaching Hospital. He brings a wealth of experience in asthma management, respiratory medicine, and cardiology, and has also contributed to development of many national guidelines in Ghana. If you're wondering how to be up to date, we just finished with learning on how we will manage asthma in children. If you want to be current and up to date with management of asthma in adults, please let's give a hand to Dr. Alanstein Darcy as she takes us to the next schedule.
Thank you very much, Dr. Damoa. And thanks so much to you and SOFPOC for the privilege of having me give this lecture. And let me say a big thank you to my very good friend, Dr. Woodry, who has done a great job and has made my work a whole lot easier. Much of what I'm going to present has been done by her. So much of what I'll present will be reinforcement of what she did. You know, asthma management in adults is quite similar to what is done in adults, just children, just a few differences. So there will be quite some overlap of what I'll present and what she has presented. All right, so what do I seek to have you achieve at the end of this presentation? So at the end of this presentation, I expect that those of you listening will be able to apply key recommendations in current guidelines in managing your asthma patients. And there are two key recommendations that I'm going to focus on. Recommendation number one is structured assessment and management of asthma patients. So that is very important. When a patient, you are managing a patient with asthma, studies have shown that asthma patients tend to miss out a lot when they see doctors. There are a lot of unmet needs when they leave the consulting rooms. So this way of assessing and managing asthma patients helps to identify the key issues that asthma patients are confronted with and which need to be addressed. And the structured assessment of the structured management of asthma entails the assessment of 3 areas that I'll talk about. They include assessment of asthma control, treatment issues, and then the assessment of comorbidities. Then the key recommendation is what is called control-based asthma management. Asthma, unfortunately, is not curable, but can be controlled. And there are 2 main recommendations for achieving asthma control. And those 2 are what are called the anti-inflammatory reliever therapy. The anti-inflammatory reliever therapy is those who have infrequent symptoms, who have infrequent asthma symptoms and only need to be on asthma medication as and when they have symptoms. So anti-inflammatory reliever therapy. And then the second way of achieving control-based asthma management is what is called the maintenance and reliever therapy. Dr. Odu mentioned it. It's abbreviated MAT or SMART. And that is for those who have frequent symptoms and therefore will need to use their inhalers daily. And in addition to that, use the inhalers as and when they have symptoms. So I'll be very happy if at the end of this presentation, every one of you learns how to assess and manage asthma in a structured manner, and also know how to achieve asthma control in your patients. So 4 key skills that I'm hoping each of you will be able to achieve is to be able to apply the structured assessment and management of asthma to identify gaps in, asthma management and then the needs of your patients. And also to be able to implement control-based asthma management. Along the way, I'll talk about inhaler technique and all that. Let me start with a case. Let me promise that I'm not going to give you as many cases as Dr. Wadri did. So this is a patient I saw some time ago, a 37-year-old woman who presented with worsening asthma the past 3 months. Unfortunately for her, she had been experiencing daily shortness of breath and wheezing, which often interfered with her night sleep. And that was obviously a bad situation for an asthma patient. She often visited her usual hospital with acute attacks and got nebulized with salbutamol. And she was given salbutamol inhaler and prednisolone tablets afterwards. In the last episode, she was given prednisolone 40 milligrams, 30 milligrams, 10 milligrams, 20, 10, and 5 on daily reducing schedule. Some people still give prednisolone this way, which is not really recommended. When you give patients, if you have to give patients prednisolone, unless you are going to have to give it for more than 2 weeks, there's no need to do the reducing dose schedule. You give them whatever dose you are going to give them to take daily. And normally for adults, it's recommended that they take it 5 to 7 days. So she began to have asthma symptoms 13 years ago when she was pregnant with a son who was 12, 13 years old at the time. And unfortunately, that child also had asthma. She had been on salbutamol inhaler, which had been working until 3 months ago when it no longer seemed to be effective. She said she was tired of asthma and was afraid she might die from it, as she had heard of people who died from the condition. And she was very frustrated that the hospital medicines didn't seem to help her any longer. So there is a patient that I had to see some time ago. And let me leave this with you. I mean, let's say you are running a clinic and this patient presented to you. Let me give you a few seconds to write down how you would approach managing this patient. So if you have the means to write, just take a paper and a pen, and then I'm giving you a few seconds to write down how you are going to manage this patient. And then we are going to do the same exercise after this presentation and see whether there will be any difference in the way you would approach this patient. So I'm sure you are the case are stuck with you. So a few seconds for you to write down your approach. Yeah, so I mean, for National Science and Maths quiz, the contestants will be given 15 seconds to answer such a question. So I think that we've done more than 15 seconds, so we'll go on. So identify gaps in the management of this patient. If we were to mention gaps in the management of this patient, what gaps would you note down? So a few more seconds to write down the gaps that you see in the management of this patient. So 15 seconds is gone. Okay, so let me say that when you see an asthma patient, the ability to identify gaps in the patient's management, then identify the patient's needs is very important to know. So I'm going to focus my presentation on this aspect of asthma management. So Dr. Wadri has taken us through the definition of asthma. I'm sure you can all define asthma. Right, okay. So how would you define asthma? And what is the underlying pathology of asthma? Any thoughts? What is the underlying pathology of asthma? Chronic airway inflammation. I agree with you perfectly. Right, let me say that I think that a practitioner's understanding of asthma probably influences how he or she manages asthma. Am I right? All right. So you people are academics, that's why you got the answer right, but out there it's not as easy as that. Let me take you a bit through the evolution of the understanding of asthma. The first person to attempt the definition of asthma was Sir Henry Hyde Salter, who in the 19th century, and by the way, 19th century was 18 whatever. So he defined asthma as paroxysmal dyspnea of peculiar character with intervals of healthy respiration between attacks. So this definition, very interesting, but it was a very good attempt. Paroxysmal dyspnea of peculiar character with intervals of healthy respiration in between. So We'll compare that with current definition of asthma and see where the gaps are. In 1952, a gentleman called N. Coombs was the first person to publish the success of treating asthma with corticosteroids. So when that was achieved, there were questions about whether Hyde's definition of asthma was correct. Was if anti-inflammatory drugs were successful at treating asthma, it triggered the thought that probably Hyde's definition of asthma as episodes of airway paroxysmal bronchospasms is probably not accurate. So further investigations were done which established that asthma is underlined by chronic airway inflammation. But what is interesting is that the way we treat asthma these days largely seems to suggest that we believe in Henry Hyde's definition of asthma more than the current definitions. Because how do we treat asthma in our facilities? Patients come with acute attacks, they get nebulized, they are given prednisolone, and then they are sent home. So there's no structured ongoing management of asthma. So this way of managing asthma seems to suggest that asthma is like what that gentleman defined it, that in between episodes, the airway is healthy. But the fact is that in between episodes, the airway of an asthma patient is not healthy. The airway of an asthma patient is always chronically inflamed, only that the inflammation has varying degrees. So based on our current definition, if we are going to manage asthma right, we need to manage asthma to deal with the underlying chronic inflammation. Now, let me say that merely prescribing inhaled corticosteroids is not good enough. The management of asthma should be structured and holistic. So this is the definition of asthma, which we've talked about. It's a heterogeneous disease characterized by chronic airway inflammation, and all asthma symptoms are respiratory. The highlights of this definition are the fact that it's underlined by chronic airway inflammation. The chronic means that asthma is as much a chronic disease as hypertension and diabetes. So we should treat them just as we treat our hypertension and diabetes. Imagine we treat our hypertensives by just tackling hypertensive urgencies and emergencies. So when their BPs go very high and they come to clinic, then we bombard them with labetalol, and then ask them to go home. We give them some short course antihypertensives, and that's it. And wait for them to come again with another hypertensive crisis. Our diabetics, we give them, we wait for them to get hyperglycemic episodes. We give them our sodium chlorphenazine, Albertis regime, a sliding scale. And then we send them home without any ongoing treatment, only for them to get another hyperglycemic episode. I mean, we definitely don't do that for our diabetics and hypertension. So why do we treat our asthma patients that way? It's a heterogeneous disease. What it means is that it's underlined by different pathologies. The key pathology is what is called a TLPA2-driven pathology, which causes which underlies allergic asthma. So when we are mindful of the fact that asthma is heterogeneous, one of the main pathological pathways is allergic pathway. We should draw our minds to the fact that the asthma patient has more than asthma. They also have other conditions. Notably, they may have allergic conjunctivitis, atopic dermatitis. They may have food allergies. And sometimes those with atopic dermatitis, when they scratch their skin a lot, they may progress to these hyperpigmented patches, which are intensely itchy. They are called lichen simplex chronicus. A few of my patients have it, and it can be quite distressing. Asthma patients may also have associated obesity, and obesity in asthma worsens control and increases the need for, increases the demand for, or increases the doses required for control. They may also have GERD and obstructive sleep asthma. So we should be mindful of these conditions as we treat our asthma patients. What are the gaps in asthma management in primary care? As I said, care is often episodic and associated with poor control. There's over-reliance on salbutamol. You can see this lady, poor lady, she's using the salbutamol and it's coming out of her ears. And she's still suffering. Gaps in asthma care. There's underuse of inhaled corticosteroids. It looks like we have some fear for inhaled corticosteroids, so we tend not to prescribe. I don't know why. Also, we tend not to assess asthma patients thoroughly. When patients come to the clinics or hospitals or especially the emergency cases, the care is usually unstructured. And we tend to have limited knowledge of evidence-based asthma management. So now let's see how we can manage asthma effectively. First of all, we should appreciate the goals of asthma management. Asthma is not curable. The main goals of asthma management are one, to achieve symptom control. Dr. Rodriguez talked about what it means to have symptom control. So symptom control simply means that patients preferably don't have symptoms at all, or if they do at all, they are infrequent and they don't interfere with the patient's sleep or normal daily activities. The second goal is to ensure that we reduce their risk of future exacerbations. The main future exacerbation, the future risk that we don't want is attacks. Because if asthma patients are going to have troubles, it's going to come from bad attacks. So now let's go into the specifics of asthma management. What is recommended for managing asthma patients in our clinics? There are two main source documents that are useful for our purposes. One is the Ghana Thoracic Society guidelines, which was published in May 2023. And then also the yearly publications by the Global Initiative for Asthma. The 2025 edition is available, and I'm sure they will soon release the 2026 edition. So what do these guidelines recommend that can help us to manage our asthma patients effectively? There are two key recommendations that I would want to highlight. And if we're able to learn these and implement them, it's going to help our patients a lot. Number one is structured assessment and management of asthma. Number two is control-based asthma management. So every one of you listening should be able to acquire the knowledge and skills of our doctors, what happens? And they found out that the way doctors treat asthma patients is not good at all. They live with a lot of gaps, a lot of unidentified needs. So a structured way of assessing asthma patients helps to close these gaps. So when we talk about structured assessment of asthma patients, when an asthma patient sits in front of you, it's a way of assessing the patient to be able to identify the needs of that patient. So how do we do that? You look at three areas or three domains. Domain number one, assess asthma control. Domain number 2, assess what is called treatment issues. And domain number 3, assess comorbidities. So let's go to domain number 1. Assessment of asthma control. There are 2 things you assess under asthma control. Number 1 is to assess asthma symptom control. To what extent is the patient's asthma symptom controlled? And what is recommended is that we assess the symptom control over the past 4 weeks. The second aspect of asthma control that we have to assess, Dr. Wadu mentioned it, is to assess the risk of adverse future events. So when the patient leaves your clinic, what is the risk that he or she will have an adverse future event? What is the risk that he or she will have an attack? So if you're able to know how to assess a patient's symptom control and then also assess the patient's risk of adverse future event, you'd have done a great job. The second area to assess is treatment issues. What do you do with regards to assessing the patient's treatment issues? First of all, assess the medication the patient is on. Is the patient on the right medication? If you look at our patient, you realize that she wasn't on a good medication from what Dr. Wadu presented. She was on salbutamol inhaler and then prednisolone occasionally, and they were obviously not helping her. You also have to assess inhaler technique, and inhaler technique has to be assessed at every patient encounter, whether the patient, you know the patient or not. I had a patient who I managed some time ago, and she was on Symbicort inhaler, but when I assessed the inhaler technique, it was very poor. Then I got her to get the technique right, and after some time, she stopped coming to the clinic. And then her auntie, who is a colleague of mine, told me that she had gone back into her poor asthma control state. So I called her to come over. And when I assessed the inhaler technique, from her records, previously she had recorded full marks for asthma inhaler technique, but this time she had declined very woefully. There's a tool we use that I'll talk about. So this person, and this lady had a master's degree. So an intelligent young lady who had been trained on the technique had acquired it, but along the way had lost it. So when they get a technique, they can lose it along the way. You also have to assess the patient's knowledge of asthma. And very importantly, their knowledge of self-assessment. If you come to my clinic, you will never leave without you telling me what you would do if you should have an attack. There's evidence to show that 65% of people who die from asthma die before they reach a hospital. So what it means is that if your asthma patient is likely to die, he will die not in your presence, but before he is able to reach the hospital for healthcare. So the key to addressing that is to ensure that the patient is empowered for self-management, especially self-management of acute exacerbations. So when I ask them, if you have an attack, how are you going to manage it? I expect them to take me through the process because I normally will train them to do so. And does the patient have a written asthma action plan? Very important. The asthma action plan empowers the patient for self-management. And what are the patient's attitudes and goals? Asthma patients have very poor attitudes, especially they don't come for follow-up. So you have to find out what their attitudes are towards follow-up. So the next area we assess is their comorbidities. Do they have allergic comorbidities, allergic rhinitis, allergic conjunctivitis, atopic dermatitis, food allergy? Most asthma patients leave the clinic with these conditions unaddressed. The patient that I presented, she had allergic rhinitis and conjunctivitis, but it had never been diagnosed, though she had been to hospital several times. Also think about comorbidities like GERD, obstructive sleep apnea, depression, and anxiety, because these may contribute to asthma symptoms and poor quality of life. So if you're able to take your patients through this structured way of assessing, I mean, don't you agree that you would have identified their needs? First of all, you would be able to objectively tell what the state of their asthma control is, identify their risk of having a future attack. You would have been able to assess issues regarding their treatment. Are they on the right medication? What is their inhaler technique? What is their general knowledge of asthma? Do they know that asthma is not quite curable? Do they know the types of medication and the differences? Do they specifically know that there are controller medications and reliever medications, and what is recommended are the controller medications? Have we assessed them for comorbidities? So this is how to assess asthma patients in a structured manner. All right, so after you have assessed an asthma patient in a structured manner, you should be able to come up with a statement like this. So Mr. Kofi Ajiman has poorly controlled asthma and is at risk of asthma exacerbation. He's not on appropriate treatment. He needs regular and as needed formoterol ICS. So if we were to apply this to our patient, this is what the statement would have to make. That this lady had poorly controlled asthma and she's at risk of asthma exacerbation. She's not on appropriate medication because she was on salbutamol inhaler. So he needs education on proper inhaler technique because if I assess the inhaler technique and realize that it's poor. And he doesn't have good knowledge of self-management. If he goes out of the clinic, you ask him, if you go out of the clinic and you have an attack, how would you manage? And he was all over the place. So you have to note that down. And then he also has persistent allergic rhinitis and intermittent allergic conjunctivitis. So this is a statement that you should make that, embraces the aspects of structured assessment. All right, so we talked about asthma control. How is asthma control assessed? So as I said, asthma is as much a chronic disease as hypertension and diabetes. For our hypertension patients, we use BP to assess them. And for diabetics, we use glycated hemoglobin or FBS or whatever. But what about our asthma patients? How do we assess the asthma control? So what is recommended in guidelines is that we assess them using questionnaires. There are quite some questionnaires available. The common ones are the asthma control test, which I use at my clinic. And then also the GINA control questionnaire, which is available in the GINA guidelines. So, and then when it comes to the assessment of the risk of future exacerbations, one of the key things we can do is to assess their lung function. Lung function tells you the risk that the patient, the risk of the patient having an attack when he or she leaves your clinic. So if we should put these two things in perspective, the questionnaire is assessing the control the past 4 weeks. And the lung function test is telling you the risk that in the next few days, he or she will have an attack. So one of my clinic sessions, I had a resident use these tools, and for the asthma symptom control, the patient scored 20 out of 25, which was a very good score. But the peak flow was very bad. So she asked me that, what does it mean? And I said, well, the patient has had good symptom control, but she's at risk of future exacerbation. Then she asked what she should do. And I said, well, the peak flow is so bad that you have to consider it an exacerbation and put the patient on prednisolone inhaler and then increase the dose of the medication. In spite of all that, that was a Friday. The next Wednesday, the patient came back with an attack. So the peak flow was telling us that the patient was at risk of a future attack. So this the asthma control test. It's a questionnaire that we can all download and use. So it has 5 questions. They all are about the past 4 weeks. So I'll just mention the first one. It asks, in the past 4 weeks, how much of the time did your asthma keep you from getting as much done at work or in school? So If the patient says all of the time the asthma kept him or her from doing, whatever, the person scores 1. Most of the time is 2. Some of the time is 3. A little of the time. The patient says none of the time, like, oh, he did everything. The past 4 weeks, there was no interference at all. He scores 5. And the other questions follow. So each question is scored out of 5. And then you sum all of them. So obviously the total score will be 25. If the patient scores 20 and above, that is good symptom control. But less than 20 is poor control. And if they score 15 and below, that is very, very poor. So that tells you how you should. The significance of the asthma control test is that, one, it tells you the patient's symptom control, and also helps you to compare control visit by visit. So if, for example, the difference is that there's a difference of 3 or more, that's a significant difference. So a patient came and had a score a previous visit. He has come again and he has improved by 3 or more. That tells you that the patient has achieved significant improvement. If, on the other hand, the patient scores less than 3, I mean, more than 3, below 3 or more of the previous visit, that means that is a significant decline, and it calls for a review of the person's treatment. We've talked about peak flow. Peak flow is a way of assessing lung function, and it gives you an idea the risk that the patient will have an attack. You can prescribe peak flow. They're available on the market. So patients can acquire it and use. Some of my patients are on peak flow, so they monitor their own asthma. One time, a patient walked to my clinic. She used to work at Ministry of Finance. Then she came to my clinic and said, Dr. Steele, I've not been having much of asthma symptoms, but my peak flow is declining. So when I looked at her recordings, I realized that they were declining very sharply. And in fact, after that, she had quite a difficult time with her asthma. So the peak flow was telling us that the underlying chronic inflammation was worsening. And sometimes peak flow can tell what is happening in the airway better than clinical assessment. So treatment issues, we've talked about it. Is a patient on recommended medicines? Any side effects? Inhaler technique, is it correct? Is a patient's self-management of asthma? I mean, does a person know how to self-manage asthma? All right, so let's look at how to assess inhaler technique. In fact, there are a number of ways of assessing asthma technique, but I'm a simple man, so I've adopted a very simple approach. I remember when I was doing my postgraduate in respiratory medicine, there was an assignment that I was supposed to present on inhaler technique, and I presented this, and my tutor was telling me that it's too simple. And I told her that she too, what she's using is too complicated for my patients. I'm an African man. My patients don't have time for complicated things. So this is the one I have chosen to use. There's evidence to it. So she had to accept it and give me some marks for my project. So this is a published way of assessing inhaler technique. It assesses only 5 steps. Number 1, does the patient open the device correctly? Is the patient able to get the device ready for inhalation? For example, if it's a PMDI, does the patient shake it? Then after that, does the patient exhale maximally? For every inhaler, before the patient inhales, they have to exhale to get rid of air in the airway, because if you don't, the air in the airway will prevent the medication from being delivered to the airway. Then after they've exhaled maximally, they have to inhale correctly. And after they've inhaled, they breath hold for up to 10 seconds. Is it not simple? And the white woman wanted me to get as complicated. So you open the device, you get a device, you prep it, you exhale maximally, and then you inhale appropriately, and then breath hold for up to 5 seconds. So in my clinic, for each score if each one that the patient performs correctly, we score 1. So at the end of the day, we get a score of out of 5. So we document the steps that are missed. So if the patient didn't exhale, we document it. If it is that the patient didn't breath hold, we document it. And then you have to correct those lapses and document that those lapses have been corrected. So these are all on inhaler technique. So I will end with the actual thing of giving patients control-based management. So when we say control-based management, it is an approach to asthma management that aims to achieve the main goals of asthma management. Do you remember the goals of asthma management? Number one is to achieve symptom control, and number two is to minimize the risk of future adverse events, especially exacerbations. So when we say control-based management, it's the kind of management that is recommended to achieve these goals. So this diagram shows the current recommendations on how to achieve control-based management. So if you look at this, it looks homogeneous, but if you pay close attention, it becomes a little simpler. So what I need you to pay attention are these horizontal panels. So you'll see two panels. Well, the first one is called the preferred controller, or and this one, the second one is the alternative treatment. So technically, what this means is how to start an asthma patient on a treatment step. Currently, as Dr. Rodri presented, the preferred asthma treatment is to use inhalers that contain formoterol and then inhale corticosteroids. And note that the word is formoterol, not formoterol. No, it's formoterol. And that is because it's been found out that formoterol is a long-acting beta-2 agonist, but it also has very early onset of action. I've gone off screen. I think it's because the diagram is homogeneous. So what do I do? Go to screen. Browser. Okay. No, this one I didn't comment. You guys did. All right, so need to open this now. So. Right, hello. Am I audible? All right, so we are going to look at how to initiate patients on the control-based management. So let's say we go back to our patients who was having daily asthma symptoms. How do you start an asthma patient who is not properly managed on the treatment? So this is the diagram from the Ghana Thoracic Society guidelines. If you look at the upper panel, it tells you what to do, how to initiate patients. So if you look here, I don't know why my cursor is not showing. It tells you, you see All right. So sorry about the interruption. So what it is that when you have a patient in front of you, if the patient has had an attack, right from the beginning, that patient should be on daily inhaled corticosteroids. And in addition to that, you ask the patient to use additional doses if he or she should get symptoms. But if the patient came to your clinic, he's not had an attack recently, then you ask yourself, how frequently does the patient have symptoms? If the patient has symptoms more than 4 days or more per week, so that is more than half of the week, then that patient has to be on daily inhaled corticosteroids plus as needed. But if the symptoms are less than half of the week, then that person can be on as needed formoterol IC. So I think that makes it very easy. Is it easy for you? So the patient is sitting in front of you. What do I start the patient on? I've been told that I have to put the patient on formoterol ICS, like Symbicort, like Fortide, or like Furacort. So how do I put the patient on? The question is, does the patient need it daily or not? If the patient has had an attack recently, no question about it, start the patient on daily formoterol ICS. But if the patient has not had a recent attack, then the next question is, how frequent are the symptoms? If the symptoms are 4 or more days per week, then that patient is going to be on daily formoterol ICS plus additional doses if he or she has symptoms. But if the patient's symptoms are only a few days every now and then that patient does not need to be put on daily medication, but on as needed ICS formoterol. So I think that is easy to grasp. So let me emphasize that not every asthma patient needs to be on Symbicort or Fortide or Furacort every day. But the patient has had a recent attack, for sure. So that is how to initiate the patients. Then going forward, these are the ones on the market: Furacort, Symbicort, and then Fortide. So going on, the next thing to do is when the patient comes to the clinic after he's taking your initial treatment, what do? You assess the patient with the asthma control test. If the patient is doing well, you maintain what you started for 3 months at least. But if the patient is not doing so well, you have to step up, increase the dose. Then the question is, when the patient is doing well, how long do you continue that therapy? Does the patient stay on that dose forever? The answer is no. There's an option to step down. In asthma management, you either step up or step down. We never step out. So I hope that is clear. So you always step up or step down, but never step out. So if the patient is doing well, you continue. If the patient goes 2 to 3 months without symptoms, then you can step down. How do we step down? When you are stepping down, assess the patient, make sure you know your patient. If it's a very bad patient in the past, for example, if he has been on ICU, that patient, do not step down. You have to maintain the patient. I had a bad patient like that, and then I tried to step down. And then the moment I stepped down, the following day, she went back to her symptoms. And then she came back to my clinic with her boyfriend. And then she pointed at me and said, look, Dr. Winkler, but I asked her to step down her medication, and then she had a bad attack. So I learned the hard way that what Gina says is true. The patient is a bad patient, you maintain them for as long as possible. But if the patient is a good patient, 3 months symptom-free, you can step down to a lower dose. You can also step down to as needed medication. So the patient was using the medication daily. Now use it as and when. But to say that, oh, now you have graduated from asthma, so thou art free, no more formoterol, that one is not good. That is stepping out. It is not allowed. All right. So the alternative is that if a patient says that for him or her, this your formoterol ICS business, he doesn't like it. He has used this medicine, and anytime he uses it, he doesn't like it. Even the shape, a medicine that looks like a bullet, doesn't like it. So he wants alternatives, then you can put him on an alternative treatment, which you can use Seretide or salmeterol ICS with salbutamol. So the alternative treatment, the liver is salbutamol, and then the controller is either plain inhaled corticosteroid like beclomethasone or Seretide or something. So what you can do is, if the symptoms are not very frequent, you give them salbutamol and plain corticosteroid. And then you tell them that anytime you have symptoms, use your salbutamol. But anytime you use the salbutamol, in addition to the salbutamol, add doses of your plain corticosteroids. If that patient who doesn't like formoterol ICS also says that or has frequent symptoms, then you put a person on the salbutamol. But this time, the beclomethasone is not appropriate. You have to use Seretide, which is a combination of salmeterol and fluticasone. There, they use it daily. And then anytime they have symptoms, they use salbutamol inhaler. So that's the alternative approach. It looks like I lost some of my slides. All right, so I think that I'll end here. So the key lessons are: know how to assess your patients in a structured manner and manage them appropriately. And then you should know how to implement the control-based management. Always manage your comorbidities. So the allergic rhinitis, allergic conjunctivitis, atopic dermatitis. So unfortunately, I didn't have time to go into that. So manage associated allergic comorbidities and you'll do a lot of good for your patient. Thank you very much.
All right. Thank you very much, Dr. Stildazi, for that insightful presentation, how we manage asthma in adults, and letting us also know that in asthma management, we can either step up or down. We never step out of treatment. Like I mentioned earlier, this CPD is proudly sponsored by Get Pharma, and we'll now give an opportunity to Farm Ejaya or say to do a brief presentation of the numerous medications they have in the management of asthma.
So a very good evening to the Society of Family Physicians Ghana. A very insightful presentation by Dr. Wodi and Dr. Stildazi. My name is Ijaya Osen from Get Pharma, and then before I start my presentation, I'd like to give a brief history about Get Pharma. So Get Pharma is the pharma arm of a group of companies in the US called Get Group. Get Pharma was established in 1995. So we've been in business, we've been providing quality health products for well over 40 years now. Majorly in Asia, Europe, and in Africa. So we've got our manufacturing plant also in Pakistan. And very recently, our newest manufacturing plant called Asthma is the only manufacturing plant in South Asia to receive a platinum certification by the Blue House Council. We are also into very quality oncology products, endocrinology products, pulmonology products, and some pain products as well. But for the purposes of today's presentation, I'd like to go on our pulmonology products called full time. That's fine.
Okay.
Okay.
Come.
Okay. So sorry for the interruption. Um, According to the 2025 General Guidelines, that recommends that in all stages of asthma, you need to employ the senses of inhaled corticosteroids and inflammatory in your asthma and COPD management. I'd like to introduce to you Fortal. Which comes in the strength of 200 microgram, 6 microgram. So Fortal has 120 doses in there. Also can be used as a reliever dose and a maintenance dose. So for the maintenance dose, we're looking at 1 to 2 inhalations twice daily, depending on the severity of asthma symptoms. Also, in mild asthmatics, we're looking at administering Fortal after when symptoms are experienced. Very importantly, Fortal is a metered dose inhaler. Benefit of a metered dose inhaler is that it's very convenient for use, especially for patients that have a low lung capacity. It's very beneficial. For a metered dose inhaler, it employs the use of a pressurized propellant method where the drug is delivered directly to the lungs. So for patients such as those that have experienced acute symptoms around the world that cannot coordinate a very strong breath in taking an inhaler. This is very beneficial. Little dose inhaler, very beneficial. Also, fortide inhaler has its ingredients in the aerosol form, and so it's very convenient to store as well, as compared to the dried powder inhaler, where in humid environments, they absorb moisture from the atmosphere and then they form granules instead of the powder. And this affects the drug delivery into the airways. And in the long run, also affects the management of asthma and COPD. So this is a diagram showing the various stages of asthma and then their corresponding symptoms that has extensively been discussed in previous submissions. Also, for the purposes of today's presentation, I put in a short video to that's on how to use MDI puffer inhaler. So I'll play the video. Okay, okay. This is also some studies to support the use of budesonide formoterol in mild asthmatics. So we got the Sigma 1 and 2 in 2018, and the novel start study in 2019, and Pascal study in 2019 as well. So as mentioned earlier by Dr. Odui, your inhaler should be a single maintenance and reliever option. Fortide has this feature as well. Fortide can be used in all trimesters of pregnancy, can be used in children 12 years and above. Very importantly, Fortide can be dispensed on NHIs as well. Very cost effective. It's recommended by the GINA guidelines as well. So I will introduce to you Fortide, the smart option for asthma and COPD management. So, So it's from our end is 80 cedis. But for the retail end, it differs from the markup from pharmacy, hospitals and clinics. It's on NHIS insurance. Yes, please. Yes, please. Yes, please. So the name is Ijay. I'll say I put this together under the supervision of account manager Asanto Aponsa, and also my key account manager Samuel J, and then my colleague Amanda Komi. So thanks very much.
All right. Thank you very much for all the presentations we have had today. Apologies for taking a little bit more of your time. There was a lot of questions coming in the Q&A, but thankfully they've been answered. Dr. Wadri and Dr. Wadri have answered most of the questions. So if you can quickly go back there and check your answers. But I'll go through some comments in the chat box and the questions. A lot of people are expressing their appreciation for the presentation, saying it was a great presentation and was very knowledgeable. Those asking if they'll be able to get the slides, yes. So how you saw the flyer on your various platforms, you will also have a link to where you can get these slides and go through so that they help you as you go on your day-to-day activities. So thank you so much. Do we have a question for those in attendance? Is there any question? Oh, you are fine. I should ask my question. Do you have a question? Okay. So please kindly.
Thank you very much. Please, my question is to Dr. Wodri. Boss, please, could you kindly go over the initiation of ICS in children between 6 and 11 and younger than 5 years? Thank you.
So for the younger than 5 years, I think I should first say that sometimes we get hung up on dosing. And for me, maybe I'm even simpler than Dr. Allen still, that's it. For me, I find it hard to I think that following up the child is far more important than the dose that you have started, and know that you can step up or step down. Now, for children, when you are starting, you can, less than 5 years, you give them fluticasone 50 microgram, or like I said, you can double the dose for beclomethasone. So that becomes beclomethasone 100 microgram. Okay, and then the next time you see them, you are assessing whether that has helped with their symptoms or not. If it has helped with their symptoms, sometimes you see the child, you start on inhaled corticosteroids and it's like everything has changed for them. So maybe then at that time they are using too much medication. And if it were beclomethasone, for instance, you could come to 50 microgram, but flixotide, that is what it is. So maybe you are now going to as needed when they take the SABA, then they take the ICS as well. So that's for children less than 5. But if you see them and you see that what you have done for them hasn't made much of a difference, so the next thing to do is to double the dose. So if you're using flixotide 50, you go to flixotide double of that dose. Just like a question in the comments, one thing about kids is that they don't like many doses. So sometimes that will mean using a preparation. So you can give them one puff of the 100 microgram. And if you are giving it daily, it's much better you use it in the morning, because that's when they go out to school, play, exposed to all the allergens or not, and so on and so forth. Now for children who are above 5 years, so but less than 12 years, again, you have to give them an ICS, a plain ICS or a SABA. So you are giving beclomethasone the whole day. You are giving them 100 to 200 micrograms of the beclomethasone. So when you start and you realize that they are not having any symptoms at all, then you want to step down, but you may step up as well. But for me, I always think that, or I know that children don't like many paths. So when it comes to stepping up, if you want one path to be 100, I'd rather go to one path to be 200 rather than BD, just to make it easy for them. But for the children 6 to 11 years, sometimes you've seen them. So there's a difference between a patient who walks to your consulting room and complains of symptoms and a patient that you are seeing in the emergency room for the first time with a severe acute asthmatic attack. So those ones, it's always recommended that you don't start on the lower doses. So you start at a higher dose. So you start at like the GINA stepwise approach that Dr. Allen Stildazi gave. You start those people at step 3 or at worst step 2. Okay, so for some of them, you may use an ICS-LABA combination, but if it is not an ICS-formoterol combination, then they can't use it as their air. So you have to add on salbutamol for them. But if it happens to be an ICS-formoterol combination, then you can use it as air, but be mindful of the fact that they need a spacer. So,
thank you so much. And how can we apply for CPD points? As you fill the link to join the CPD, if you put in your MDC registration number, you'll be credited when MDC approves our CPD points. So you don't need to worry about it. Without wasting much time, we want to bring this meeting to an end. And we are truly grateful for the opportunity granted the Society of Family Physicians of Ghana to hold this CPD. Like I mentioned last week, we are having a series of 7 free CPDs coming up in the month of April and then May, as we gear up to our AGSM coming up from 22nd to 24th May at Western Premier Hotel at Takoradi. So please join us on Thursday. Our next CPD is coming out this Thursday, where we'll be talking about current management of hypertension in the patients that we see in our primary care. As we go over our various duties at the OPD, we see a lot of patients with hypertension. So please make a date with us on Thursday, 3 p.m. as we go on to our next CPD. Thank you so much for the opportunity to join this meeting, and good night.